That's okay. Hey, Jared. Good morning. Good morning. Pick it up.
Thank you.
Karen. Good evening.
Good evening, and thank you so much for coming tonight. My name is Nancy DeMack, and I am a very grateful member of First Congregational Church. And I am here to welcome you tonight to our first in the launch of our premiere of Wellness Series. Today marks the beginning of something very meaningful. It's a shared space where we can explore the reality of health, the challenges of everyday life, and the opportunities we have to support one another as we grow older. The series is rooted in a simple but powerful idea. None of us has to navigate aging or with the health conditions that we may come to alone. Whether we're managing chronic conditions or maintaining our mental health and emotional well-being or adapting to life's transitions, we all these experiences are those that connect us. Over the coming months, our goal is to focus on what we can do together, how we can listen, learn, and uplift one another. Because wellness is not just an individual pursuit, it's built through community, connection, and shared resilience. So let this be a place of openness, a place where questions are welcomed, and where every voice matters. Now it's my pleasure to introduce Nancy Redeker. Nancy is a professor at the University of Connecticut School of Nursing and serves as a Senior Associate Dean for the Research and Scholarships. She is also the Beatrice Renfield Terms Professor of the Nursing Emeritus at Yale School of Nursing. For more than 30 years, her research has focused on sleep health among individuals who are at high risk for acute and chronic conditions, as well as the development of interventions to support improved sleep in both clinical and community settings. Her current work includes studies on sleep among women and young families, clinical trials for insomnia and sleep apnea treatments, and research examining how sleep deficiencies may impact relapse and retention and medically assisted treatment for opioid use disorder. Please welcome me and please join me in welcoming Nancy to
Hi everybody, thanks for coming. As Nancy mentioned, this is the first in a series of what we hope to be about a quarter of the series on health talks, and I think you've all seen there's an opportunity to give us some ideas if you have other ideas for upcoming events or speakers. And we'd also love to have your email address so that we can develop a list of people with interest in this series. So what I'd like to do tonight is to really give an overview. Sleep is a pretty broad field. I spent about, I would say, almost 30 years or so on various aspects of research, but increasingly important to make sure that the community is aware of these issues. I did start my career as a coronary care unit nurse, so I won't go over all the gory details, but my first project was looking at sleep in recovering cardiac surgery patients, and if you've ever recovered from the hospital or from an event like that, you know it's really a problem. What we found was, yes, sleep is really important to our quality of life, and if we improve it, we can improve that. So with that being said, my work has become much broader, but I think this idea of building it out in the community and making people aware of the concerns is really important. As you know, in health we often talk about physical activity and diet, but we rarely also talk about sleep, and all those three things go together for everyone across the lifespan. So this is just a brief outline. I'm an academic, so I always have to give objectives. But, so, what is a good night's sleep? We're going to talk about how does sleep affect our health. Then we're going to talk about what factors affect our sleep. And I mean, I could talk probably several hours on each of these topics, but we're going to be very brief. More importantly, what are the best ways to get a good night's sleep and when to ask help? And Dr. Adam Perrin, who is a physician at UConn Health, is going to get up at the end and talk about his experience with treating sleep apnea, just to round out the evening. And I hope, I have a lot of content here, but I want to make sure that if I talk too fast, let me know, because that's a habit of mine, but I really would like to leave time at the end for questions. So here's some myths. I thought we'd start the talk with that. There's a lot of things and misunderstandings about sleep. So the first one is you need less sleep as you age. As I go through the talk, you'll see why these aren't true. You can cheat on the amount of sleep you get. How many people have heard people say, oh, I can sleep 3 hours at night and I'm just fine during the day? Well, if I bring you into the lab and I measure your vigilance, we can see that that's absolutely not true. You're trying to keep yourself awake and you don't even know it. Turning on the radio, open the window, or turning on the air conditioner may help me stay awake while driving. No, that's not true either. Teens who fall asleep in class have bad habits and are lazy. Dr. Sadler and I, Dr. Sadler is here tonight, did a project with her colleague at Yale where what we found was teens were all telling us, I'm too busy to sleep. They were doing too many other things. And no, they're not lazy. We can talk about that. Sleep disturbance is a normal part of aging. You know, if your sleep changes, you may need to get followed up and see if there's some other things going on. Snoring is normal. The best way to fall asleep when you wake in the middle of the night is to toss and turn. Right? So these are very common misconceptions, and I hope that we can explain to you why these are not true. So what is healthy sleep? A lot of us think it's only about how long we sleep. And there's a lot of research on that showing that short sleep is bad for us in many ways. We show it's related to hypertension. We show it's related to heart disease. But increasingly what we're finding is it's not just getting enough sleep, it's having sleep that's regularly timed throughout the day and from the weekends to the weekends. And so that's what we call our circadian rhythm or our daily rhythm. And the more regular that is, the better for our health in many respects. Not only our sleep, but our behavior and lots of our biology, which we won't go into tonight. The other important thing about sleep is that high satisfaction. Are you happy with your sleep? Is it good sleep quality? And then finally, and I'm not going to get into all the details of how we measure all these things, but high daytime alertness. Like, are you alert during the day and able to do what you need to do in a safe way? So the other thing, and this is a little bit complex, but we all talk about the post-lunch dip, right? We all talk about, we make jokes when I give talks, we talk about if you talk after lunch that everybody's going to fall asleep. Well, that's actually normal physiologically. The dips in our alertness or awakeness are at 2 a.m. and 2 p.m. And that's normal physiologically, right? So it's to be accepted. For some of us, if we take a nap at 2 o'clock in the afternoon, that's not necessarily a bad thing. So just in sleep and our alertness, which goes along with that, has a daily rhythm. I used to be a shift worker, so we're not going to talk about shift work tonight, but that's the other part that really is problematic. But that is related to this, and again, this is kind of confusing, but there's two things to remember. Sleep is dependent on two things. One is, it's sort of like being hungry. Your homeostatic drive. The longer you stay awake, the more tired you get, right? That's logical, right? But the other point is that it has that rhythm that happens across the course of the day. And so that's why when I was a shift worker and I worked nights in the coronary care unit many years ago, we had little children, the reason that I couldn't sleep if I came home on a Saturday was because my body was primed to sleep at night. So I was really, really tired, but that's why if you stay up all night, it's hard to sleep during the day, because two things are going on. One is you have a lot of sleep drive due to being tired, but the other one is opposes your normal rhythm. So that's why timing is also important. And in effect, we're increasingly learning this affects all the cells in our body. It's not just our sleep. So the other thing that's important, and we have people of all different ages here, some of you have children, is that sleep does change over our lifespan. This is kind of an old picture, but if you've had newborns or you have experience with babies, they sleep in little snatches throughout the day, right? As they get older, 1-year-old, for example, will sleep longer at night and maybe take a nap or two in the afternoon. As they get older and older, they give up their naps, And as they become an adult, it's normal to sleep during the day and not so much at night. Now, it's not terrible to have a nap now and then, but this is sort of normal developmentally. What doesn't show here, and for those of you with experience with teenagers, is it's normal for teenagers to want to be up late at night and then sleep in the morning. And we all get upset. Jim and I have a son who used to sleep till 3 o'clock in the afternoon on a Saturday, and I used to scream at him to get out of bed and go help his father in the yard. But that 3 o'clock was a little over beyond the pale. But it is sort of normal for adolescents, and that's what one of the public issues we have today is that high school starts really early in the morning. That's one of the reasons for that. So this rhythm, the timing, as well as how long you sleep is really important. So I'm going to skip through this, but basically the message is lots of people complain about sleep problems. Lots of people don't get enough sleep. They often sleep more on the weekends, but we like to see it more regular throughout the week. So, why do we care? Well, we care because sleep affects almost every aspect of our health. It affects our high blood pressure, and for example, if you have poor sleep, your blood pressure normally drops about 10% at night, and if you don't sleep, it doesn't drop. So even if you don't already have high blood pressure, that could contribute to future high blood pressure. Contributes in many ways to, and we're going to talk a little bit about sleep apnea in a bit, but short sleep, irregular sleep, all of these things affect our heart. They contribute to our diabetes, as well as mood, and increasingly, we're seeing that poor sleep can contribute to dementia, and for example, Alzheimer's disease. But we also know that poor sleep is related to immunity and infection. We had a small study at Yale. We were looking actually at the response to immunizations. And if people slept better, and I don't know how much went on with COVID, but I'm guessing there might be some work around that with immunizing people and their response to vaccine. So it affects there's huge amount of research on both the biological and sort of the patient-related connections here, but this is why we care. But the other thing that sleep loss affects is our performance. And so I think it's kind of logical that people are sleepy during the day if you don't get enough sleep. But also memory impairment, decision-making. For those of us in healthcare, having insufficient sleep can cause medical errors. It affects academic performance. Increasingly, we're interested in the performance of athletes and do they get adequate sleep? And of course, our quality of life. So this is, again, an old graphic, but this is an example. Before I mentioned that people are, that we have to pay attention to our alertness, right? So this is a graph showing the time of day of motor vehicle crashes. What do you notice here? So the biggest time of day is from 10 o'clock to, it's from in the middle of the night. So see, midnight is at the beginning there. Midnight to 8 o'clock or so is the highest time of motor vehicle crashes. That's not because it's dark. That's because people are falling asleep behind the wheel, right? And so, and even if you think you're wide awake, if you didn't get sufficient sleep, you may be more impaired than you know. There's a very famous research group at University of Pennsylvania where they actually experimentally sleep deprived people, and then they brought them in and they tested their reaction time and all the things you need to drive. And what they showed was, it was very clear that shortening sleep affects all of that. Stay off the road in the middle of the night, I guess is the message, right? So the other thing that we don't think about very much is the cost of sleep loss. So it clearly affects our workplace productivity. If you're falling asleep on the job, again, if you're making errors at work, it affects school performance. As I mentioned, we had a project where we looked at children's school, and the school nurse, these were high school students, and the school nurse came and said, these kids are all falling asleep in class, like, what can you do to help me? The guidance counselor said it, the teacher said it, everybody said it. And when we interviewed these families, we interviewed the teachers, we interviewed the guidance counselors, And the take-home message, and I think it was a major theme in the paper, was we don't have time to sleep. So the kids were, trying to get into college, doing their homework, playing sports, had an after-school job, and they just did, and of course on their screens. That's the other thing we didn't talk about. So it was a pretty big deal. And then the other cost is sleep treatments and treating other medical-related outcomes of it. So this is a big deal, bigger deal than, again, we often talk about nutrition and physical activity, but we need to think about those things as a trio. So again, this is kind of busy, but I wanted to make the case that this is complex. So there's multiple things that contribute to our sleep, right? If you look at the top, we often think about things like, I don't feel well, I have pain. Well, that's one influence, but if you have pain, sleep also makes your pain worse if you don't sleep well. So we have medical and psychiatric things on I guess it's the right side of the slide. Primary sleep disorders, we talk about that in a minute, but we also have many other factors, right? Things like, what's your home sleeping environment like? Is it noisy? If it's noisy, could you, use some way to make it more quiet? Do you need room darkening shades? Is it bright light? If you live in a brightly lit neighborhood, is it hot or too cold? All of those things can contribute to our sleep, and there's things that we maybe need to do as a society, and we can talk about some of that if it's in your neighborhood or whatever, but there's also things you can do to create your own environment at home. The other thing, volunteer activity, and I should have put in capital letters, electronics, your screen time, right? I know better, and I'm reading my iPad before I go to bed at night. That light is an alerting stimulus coming from the device, right? So, and we know that the screen time is, for example, with adolescents, one of the biggest drivers, right? And there's some research that we've looked at that's not only the bright light, but it's the stimuli of that social interaction and the that emotional arousal that it causes to interact with that device. So the best thing you can probably do is get rid of your device at least an hour before bedtime. Certainly substance use, alcohol, medication. I'm going to talk about alcohol in a minute. But the other thing that we're increasingly interested in is the social environment. So people that have not enough resources often live in noisy, crowded, or violent environments. Maybe there's too many people living in the apartment, or they don't have the means to make it quiet and dark. We recently, just this week, defended a dissertation with one of our PhD students where she looked at mapping information about neighborhood violence and lighting and green space. And guess what? The green space, these were people from all over Connecticut, guess what? Living in a place with more green space was associated with better sleep, right? So should we be putting, so this is a social issue as well as an individual issue. So if you live near a park, you have green space, your sleep is better. It was worse if you lived and you reported a lot of violence in your neighborhood, because obviously that's very upsetting. So it's multidimensional, and if you are struggling with your own sleep, think about your immediate environment and maybe the environment beyond that. So when you have a sleep problem, and particularly I'm talking about a problem called insomnia, which is a problem associated with having trouble falling asleep, staying asleep, or waking too early in the morning. There's some things that are sort of part of us that make us more likely to have the problem. So one thing is certain kinds of personality. There's some genetic predisposition to having this problem. And there's sometimes it has to do with age. So those are things these are all things you can't really change very much. And when we treat insomnia, we think about that. We try to evaluate those things and help to see, how we can help people adapt to this situation. But the other thing that causes it, and I'm going to tell you this is a picture somebody gave me years ago, and I'll tell you why, is situational things. Things like being in the hospital. Things like having a medical problem, things like losing a loved one, sometimes changing your prescription medication. So there's a whole range of things. And so I hope this doesn't really look like me, but I started doing research on this topic around 30 years ago, and I also was a nurse in a hospital, and I used to work nights. And guess what? In the old days, before we had all these devices, we used to go, Nancy's laughing because she's a nurse. I used to go around with my flashlight, and I had to make sure that once an hour we had to make rounds, right? And we had to make sure everybody was breathing, right? And if you couldn't wake them up, you knew it was really a problem. Anyway, this was a unit with heart patients, right? So this was really a concern. And so she says, just wanted to know if you're still having trouble getting to sleep. So if any of you have had an overnight stay in a hospital, you know nobody sleeps in a hospital. We are actually doing some work at Yale. I'm still collaborating with some people there where we're trying to address that. But it's a tough nut to crack, needless to say. But those kinds of things may start you on a chain towards having insomnia, right? It's not just the immediate event. It sort of sets you on the path for your brain to be starting to struggle with sleep. So sometimes these have long-term effects. Certainly, I'm having psychiatric sorts of problems as well. So the other thing, though, once you have a sleep problem, there's some things that make it worse. So you get conditioned. You say, oh my gosh, I can't sleep. I'm just going to go to bed, and I'm going to toss and turn. And I equate my bed with being an unpleasant place, right? We do teach people, use your bed for only two things, sleep and, that's church, but sleep and sex. It's the only, if you have trouble with your bed, that's what we tell people. And so what do people do now? They live in their bed, right? You watch TV in bed, you eat in bed, you hang out in bed. And the problem is then you're not conditioning yourself to using the bed for sleep, right? The other thing is substance abuse. Now there's a real misconception about substance use. There's a misconception that if I drink, I'm going to make myself go to sleep. Well, that's actually not true. Alcohol makes you sleepy, but it actually dehydrates your brain, which is why you wake up an hour or two later. And so, but continuing to do that or using other kinds of substances makes your sleep even worse. The other thing is performance anxiety. So when people start to develop insomnia, they go to bed and they say, oh, I'm really not going to sleep tonight. And of course, if you say that, of course, you're not going to sleep tonight. You sweat it out, right? You get upset about it. And then I mentioned electronic devices. And so there's just a whole lot of things that make it worse. And so if you're struggling with your sleep, think about what some of those things might be. And there's help for that. I mean, we can talk about that. So I put this in here just to elaborate on the point about alcohol. So will a small amount of alcohol affect my sleep? So on the yellow picture here, a low amount of alcohol decreases sleep quality by about 9%. That's less than 2 drinks for men and less than a drink for women. A moderate amount by 24%. That's 2 drinks for men and a drink for women. And high amounts, 39%, is more than 2 drinks, and that decreases it by 39%. So this is just some data to show this is really a problem. So yeah, it makes you feel sleepy, but it's really not helping you sleep. I wanted to talk, I did a little bit of research because it's not really the space I'm in, but there's a lot of people now using cannabis to help them sleep. And some people say it really, really helps, but the research is very mixed on what it really does or how much it actually helps. And part of that is because cannabis is not well controlled. We don't get, all the products are different. And we don't know the dose, and we don't really know how much product is actually in it. So there's a lot of mixed work on that, but a lot of people, particularly older people, are now trying it out. So Adam, I'll be interested in your perspective of that as a prescriber. But so all of this, I mean, this is, a lot to digest, but what are the best things to do in your handout? By the way, I created that handout with ChatGPT. I did check it, and it was accurate, but it was very easy. I said, give me a handout on sleep tips. Not bad. They don't need us anymore, but I could have developed my own, but this only took a couple of minutes and then just printed it. So the best thing to do, consistent wake-up time, keep the same times on weekends and weekdays. Try to avoid naps. Brief naps are fine, but don't sleep in bed all day. Avoid exposure to bright light before bedtime. We actually just published a paper, or some of our research was looking at sleep in people with heart failure. And the device we use actually measures light. And guess what? We found out that exposure to light, not only did it give them before bed, because we could time it, it was a 24-hour day, not only didn't they sleep as well, but they had that poor brain function, poor cognition. Turn off your electronics an hour before bed, and it's really important to exercise, but it's best if you exercise early in the day. So the other thing, and this may seem obvious, but having spent some time in a sleep clinic, it's not as obvious as you think, because when you start to ask people, it's not always a comfortable sleeping environment. A cool temperature, quiet, dark, and I mentioned the bed, the purpose of the bed. Comfortable bedding. And sometimes things are easy. Maybe it's just a new pillow, right? Maybe it's or a different cover. So the other thing that's really important is to do something relaxing and enjoyable before bed. And people find different ways. And this is across the lifespan. Again, we've done some work in pediatrics. Some people find it helpful to take a warm bath. Have a routine, right? Read something soothing, not the murder mystery, right? Have a regular sleep routine. You brush your teeth, you put on your night clothes, you go to bed. This is very simple, but it actually is shown to be effective. Some people like to pray or listen to quiet music. One of the projects we did with young children in the community, the mothers told us that they would massage the child with lotion before the child went to bed. For children, read a story. There's really good evidence that children who have that regular sleep routine, and you read a story every night before they go to bed, or pray with them, or massage them, having that regular routine really helps with sleep. So, what to avoid? Well, you don't want to go to bed on a full stomach or hungry, so don't eat that pepperoni and pizza an hour before bedtime. Don't exercise in your bedtime. You need to get that last little exercise in, but don't do it at bedtime. We mentioned alcohol already. Caffeine, try to avoid it within 6 hours. Some people, even decaffeinated beverages have caffeine in them, some of them. And if caffeine bothers you, you may want to avoid it up to, afternoon, anytime afternoon. If you think it bothers you at all, just avoid it. But the other thing, and one of my mentors many years ago, she was a nurse who was also a psychologist. She used to tell people to keep a worry book next to their bed. She used to treat people with insomnia. And so what happens is you go to bed, you're worrying about something, and you think about it, and you think about it, and you think about it, and you wind up your mind, and it keeps you awake. So she used to use this strategy. She'd tell people, keep a diary next to your bed, and write your thoughts in the diary before you go to sleep. And that way, psychologically, you're putting it aside. So that may work for, that may be helpful. So this is a very old version, but the other thing that some people find helpful, and there's many, many different versions of this, I just pulled this one off the web, is to keep a sleep diary. And what that helps you do, in the diary, I went to bed this time, I got up this time, I took a nap. Some people even write notes about what happened during the day. And if you look at it over a series of days, you might see a pattern. And you might see behaviors or things that you want to change to improve your sleep. Now, the other thing is, this is a paper version. There's all kinds of versions electronically that you can use on your device. Don't read the device before you go to bed, but there's all kinds of things now that are electronic. So that helps. And then when we treat people with insomnia, we use a device like this to help they actually bring it into the therapist and say, okay, and then the therapist helps them adjust. Well, maybe you did this, maybe you did this, maybe you should do something different. Were you having pain, right? Was there something else going on? And that helps you identify what the triggers are to your poor sleep. So that's one tool that you can use. And again, if you go for treatment for insomnia, behavioral treatment for insomnia, this is one of the tools that we use. So this is kind of an old slide, but I always laugh because now we all have some kind of a smartwatch or device. And I walk through the halls at UConn or Yale when I work there, and everybody says, oh, my watch says I got this many minutes of REM sleep or whatever. Well, your watch probably wasn't looking at your EEG and electroencephalogram and probably doesn't really know if you had that much REM sleep. And the other challenge with, I won't mention brand names, but I'll mention Fitbit and all these other ones, right, is that they all have little different physical properties, right? And they're all using some computer program to estimate your sleep. Most of that has been compared to the gold standard, which is in the sleep lab. But they're all kind of, if you do 5 different devices, they're all going to tell you something different. So what they are good for is if you wear it from day to day to day, it helps you understand what you understood in that sleep diary, right? To say day to day, I can say, oh, yesterday I didn't sleep very well, I wonder what was going on. Or yesterday, I went to bed later, maybe I should keep a regular time. They help you to track how you're doing with whatever you're doing with your sleep. So from a scientific kind of view, which in my research, for example, they're not all interchangeable, but they are giving us important information that might be useful. So I'm going to switch gears a little bit here. It was a really sort of brief thing. I'm going to talk about, there's many different sleep disorders, and that's one of the challenges. When we treat people with sleep, there's a lot of different sleep disorders. And I think that's one of the challenges, is that we often say, I did a survey once of some healthcare providers, and we presented a case and we asked them to figure what their first step was in helping this person. And some people automatically assumed the person had insomnia. Some people assumed already they had sleep apnea, and they didn't all have the same approach. But part of that is not their fault. Part of that is because sleep is sort of, as we mentioned, it's not just how long you sleep, it's what happens during your sleep, it's the timing of sleep, and all of those lead to different sort of outcomes. It's not like I can say I can measure your blood sugar or your cholesterol level and I have a pure number, right? There's lots of different factors that go into it. So there's 2 ones I want to talk about, and these are the ones common in adults. And I know church on Sunday after church, several people came up and said, I can't wait for your talk because I have sleep apnea, or I'm being treated for sleep apnea. And that's one. And so the two most common in adults are obstructive sleep apnea, which is, I'm going to have Adam get up in a minute. It's about 20% of the population, although it's probably underdiagnosed. It's more common in men than women until menopause. And then it's about equal, and it presents differently in women than men. So, but it's very common. I'm going to hold on that. The other problem, which is just started to talk about, we talked about behavior, is chronic insomnia, and that's what I mentioned. This is a problem where you have difficulty falling asleep, like it takes you too long to fall asleep. You wake up a lot, or you wake too early in the morning. And it's usually frequent, 3 or more times a week, and it's not explained by another health problem. So it may not be explained by the fact that you have severe pain, or you have something else that just, or some respiratory problem that's keeping you awake, or something like that. So the treatment for that, the state-of-the-art treatment, there's 2 things we do. We do behavioral treatment and we do medications. And a lot of people go right away to medications. But what the literature shows, the research shows, is the best way is this behavioral treatment. And we did a trial on this with heart failure patients at Yale, and not only did we improve their sleep, but we improved their fatigue and their function, which for those people is a really big deal. So this focuses on those things I was talking about before. It focuses on changing your behavior and your thoughts and beliefs. And there's multiple steps to it. Sometimes it includes stress management. We had some of that in ours. But the important thing is it lasts longer than drugs because it changes your behavior and in the way you think. It has very few side effects, lots of satisfaction, and you can do it in multiple ways. The standard way is to go to a therapist for 8 or 10 sessions, which is time-consuming and expensive, and sometimes it's given individual, sometimes it's given in a group, but increasingly now, we have online approaches. So you can, you should go get evaluated by a sleep specialist if you think you have this problem, but it's available now online. So there's lots of ways to get at this. The other thing is medications. This is very busy, I won't go into it. There's many different prescribed versions. Some of them are drugs that are given for other purposes, like trazodone is actually an antidepressant, but it has sedating effects. But the one thing I want, and a lot of people are doing herbal remedies. The challenge with herbals is it's really hard to look at how effective they are because they're all sort of different and they're not regulated in the same way. A lot of people are taking melatonin. If that helps, that's probably a good thing. Again, the data's a little mixed. But the one thing, especially if you're older, you should be careful about is a lot of people are taking the diphenhydramine. The brand name is like Benadryl. It's in a lot of cold medicine. It's in a lot of things. In our studies, some of the people were taking it and they felt very tired and couldn't go about their daily activity. And so this is probably not a good approach. So these are all prescribed, and you should talk to your prescriber. I don't want to belabor this. But really the long term, and the research shows this, the best way to treat insomnia is really that behavioral approach. Some people use both, and some people use the medication, and then they go use the behavioral treatment to, as they're tapering off the medication. In fact, we did medication tapering on intervention. So I'm going to let Adam come up. I'll let you come up because this is just descriptive. You can use it or not. Adam is going to tell us a little bit about sleep apnea.
Thank you, Nancy. Wonderful talk. It's a great review. Hopefully new information for everybody out here. All right, so hi everybody. If you don't know me, I'm Adam Hira, and I am a family physician by training. And I see a lot of this in practice. And I want to speak to you as somebody who's on both sides of the coin. I'm a prime patient for obstructive sleep apnea. As well as somebody who treats it, who screens for it and diagnoses it and treats it regularly. So, what I'm happy to say is that it is much more of a focus than it used to be. When I was training at Middlesex Hospital over 30 years ago, whenever a patient would present with fatigue, and that's typically a presentation, just feel tired, can't move as well as I used to, and falling asleep fairly easily, we never even considered OSA as a potential cause. We would investigate many other possible etiologies, such as anemia and diabetes and low thyroid or even depression, but this was not considered. And I'm grateful now that it's become much more of a focus. So from a personal perspective, it's already exhausting enough to be a resident. For any of you who watch medical shows like The Pit, you know how absolutely exhausting it can be. And I did that kind of work for a while in the 90s. Thankfully, no more. But God bless my long-suffering wife, who had to endure god-awful snoring. And I really, to this day, thank her for not divorcing me, because it can be a significant stressor when it comes to stable marriages if you cannot tolerate the noise of your partner's snoring. So I was chronically fatigued, worse than usual, and finally, when it came more into vogue and a focus of fatigue or daytime somnolence workups, I finally went for the definitive evaluation, which includes primarily, in order to confirm it, we first do a screen of simple questions to ask. You know, are you falling asleep easily during the day? Do you feel chronically fatigued? That kind of thing. And it has to be confirmed through a sleep study, a polysomnogram is what it's called. And I had mine done, and severe, really severe obstructive sleep apnea. And there you go, so confirmed diagnosis, and then you have to get it properly managed. So just quickly, in terms of those most at risk, Nancy had touched on that, but
My next slide. Click the next slide.
there we go.
Yeah,
This-
here, I said what it was. I think then the next, I think I have.
Well, this is good, this is perfect. I'm a prime example, a big dude, all right, who has a thick neck. All right, so most of the people who tend to be on the larger side, usually men, on the larger side who have thick necks, because it really is a mechanical issue. And Nancy puts it up here. When you consider when you're supine, lying down, you have a lot of excess tissue, perhaps fat, in and around your neck. There's a propensity for the airway to collapse. It's as simple as that. And there's a lot to do with your tongue size and how much tissue you have in and around your neck, but it's just a matter of collapsing so that during sleep, and that produces, with the passage of air back and forth, the snoring sound. And if you think about it, significant deprivation of adequate oxygen. So what happens physiologically with sleep apnea is that multiple times a night, your body is waking itself up. Like when your brain is deprived of adequate oxygen because you're not moving enough into your lungs, there's a trigger response that wakes you up. You don't remember it, but it happens repeatedly. For me, on a sleep study report, it was literally happening about 70 to 80 times an hour. All right, so, and that prevents you, so that's a good thing that your body is waking itself up, because if you think about it, imagine all that oxygen deprivation to both brain and heart and other vital organs. You're thankful that your body is waking itself up in order to get an adequate breath in. But you're never allowed to go into a deep restorative REM sleep. It never happens. So as a result, you wake up absolutely exhausted. And the risk factors are significant. And this is just what I counsel my patients on. With that repeated deprivation of oxygen to vital organs all night long, think about what risks that poses. So blood pressure can be made worse. Heart attack, stroke risk becomes higher. Headaches are exacerbated. I've had many cases where patients will come and say, I just have chronic headaches and they're really bad in the morning. Well, once you realize that OSA is the likely cause, you treat that and you can take care of the headaches. Depression is exacerbated, so many things are made worse by it. And it's actually very helpful having the subjective experience of being diagnosed and treated, and I can impart that upon my patients. I'll say I'm a prime example of all that can be fixed and how life-changing it can be to get this adequately treated. I can't tell you how much being on CPAP was tremendously life-changing for me. It just turned everything around. So that, as most of you know, if you've read about it, or some of you out there probably do have OSA, CPAP, which stands for continuous positive airway pressure, is the primary treatment.
Sorry, and then I interrupted you.
That's all right.
I always do this once every talk, so.
There we go, there it's going. There we go. Yes, so there it is at the top. So that is the primary treatment. And, it's something that requires getting accustomed to. I am not a proponent of the mask whatsoever. I tried that, and number one, it makes you feel claustrophobic. Number two, you get a fair amount of air swallowing that makes you distended. But I find the nasal pillows are absolutely beautiful. They're just two little soft pillows that just rest right here in your nose. Your mouth is uncovered, and the The high pressure goes through your nose and keeps the airway under pressure open all night long. You get used to it, it's quiet, almost silent. CPAP machines are more and more portable these days, they're very small. So that is primary treatment, and you can bring them everywhere. Of course, TSA is very used to scanning CPAP machines. In fact, they're so common. Allison and I get together with my residency friends, and there is literally a brotherhood of the CPAP. The majority of the men in our group have a machine. It's really something to behold. So that's the primary treatment, but there are indeed other, and weight loss is always encouraged. It definitely makes a difference. But there's dentists that have special training. You'll see advertisements for sleep dentists. Mainly just a matter of fitting an appliance that forces your chin forward, and with your chin, your tongue, in order to maintain an open airway. And there are surgeries which we rarely do. Those are the worst cases. And then there's this thing, Inspire.
So Inspire, it's sort of like a pacemaker, but it works on your diaphragm, yeah.
That's right.
Yes, you see, that's the commercial you see in the evening with the people that's in the gray bedroom, and then all of a sudden the bedroom lights up. You see that ad? It's that company.
That's
yeah,
right. It's
implanted like a pacemaker.
That's right. There's lots of restrictions, though. I did try to refer patients for it. There's a weight cutoff. And getting coverage for it. So, majority of what you'll see is the CPAP machine. And I find that, insurance companies, they won't give you a CPAP until you have confirmation with the sleep study, the polysomnogram. And as you can imagine, sleep labs are getting real backed up. It's a good thing that we consider this diagnosis, but the providers that diagnose are getting pretty overwhelmed. So they do offer home sleep studies, and that's always what I
That's becoming pretty much the norm, is home
Yes.
sleep studies. You take it home and you wear the device and bring it back.
I love it. It takes much less time. And also when you're in your home environment, when I had my sleep study, you go to this foreign lab, you've never been there before, they attach you to countless gadgets, and they're looking at you in the video all night long. and it's just unfamiliar foreign, and I was not comfortable, so it's much more likely to get to sleep in your own bed with a simpler device. And they're good. They give you the information you need for confirmation, and then with that, you can get your CPAP. That's pretty much what I have.
Yeah, and so there's you've all heard about these GLP-1s.
Yes.
These are the ones on TV where they're talking about treating diabetes and obesity. There's some new evidence, and this is actually FDA approved for some people, for these drugs that apparently they treat sleep apnea. What we're not really clear about, they also make you lose a lot of weight. So did your sleep apnea get better because you lost weight, or was there some other direct effect? But that's the hot thing. And I did want to comment on the oral appliance. A lot of times, those just sort of help your snoring. They don't, just because your snoring went away. And by the way, you can have sleep apnea and not snore. So that's one of the challenges there. So they don't always work. But Adam's right. I mean, the gold standard. And I had all kinds of other pictures, and I cleaned up the slide. They have all different kinds of appliances now, and they will work. The lab works with you to make sure that there's one that's comfortable. It's usually they send a company to your home that helps you with that. So there's all kinds of ways. The big challenge is that people don't always find it comfortable, and adherence is an issue. That is the biggest issue. Like, a lot of people are looking at, well, does it help your health long term? And a lot of studies have been not real convincing, but we don't know if that's because the treatment doesn't have that. They do it makes you feel better, as Adam said. We don't know if it keeps you alive longer, but part of that is because we don't know how well people are using the treatment. So I will share this later if you like. These are a lot of publicly available sleep resources if you want more information. I'd be happy to make a copy of this if you're interested. All of these have information that's digestible for the public and for patients. I did put American Academy of Sleep Medicine. If you are a patient, you actually have a clinical sleep disorder. There's actually information for providers here as well. So, and then we have some time for questions, but before we do questions, I didn't want to leave out Adam's talk will be on June 22nd, and he's going to talk about social isolation and loneliness. There's little cards if you want to take one. Anyway, so I'm happy to, and I'm sure Adam would help as well if you have some questions. Quiet group.
So if you're taking a long airplane trip,
Yeah.
how do you sleep?
Well, a lot of people, I don't have the prescription in front of me, but there's a lot of people that are manipulating, they're using melatonin and other things to manage that. Adam, do you want to?
Yeah, so jet lag.
Yeah.
And so I think the essential recommendation is to try to stay in your sleep schedule, no matter where you're going. So, if you're on a plane and it's bedtime for you, Eastern Standard Time, then you should make an effort to go to sleep.
Keep the same schedule.
Keep the same schedule. And if that requires a drug, that's okay. A Benadryl, that's often adequate for people. That's fairly standard OTC sleep medication, after an injury. But that's the primary recommendation.
So what about, I have this chronic problem, I call it hip pain, but maybe it's sciatica. Any suggestions for how to deal with that? I mean, as far as I do try to do hip opening stretches before I go to bed, but my hip pain bothers me in the middle of the night.
That's a separate talk.
We got to do what I'm paying, right? Yeah.
The whole
Okay.
thing, right?
Yeah.
See me afterward also.
Ernie.
Yeah, I just wanted to at least see if you have any comments about the awakening process, that they find that cardiac events happen mostly between 6 and 10 a.m.
So that is actually biologically true, and it does have to do with your sleep and REM sleep, and there's a lot of what we call, it's a lot of arousal, a lot of your body is very, it has to do with REM sleep and sleep stages and the physiology of that.
Yeah.
So that's actually
mainly,
accurate.
it's mainly regarding not turning on your stressful devices immediately,
Yeah.
and hydration before caffeine, a few other things that I recently just sort of heard somebody.
Yeah, but it is actually physiologically more likely, regardless of all that, it has to do with your EEG and cardiovascular activity at that hour. Bogan has seen that. We need a psychiatrist.
Yes, I
to tell us
have
about it.
a chicken and egg question for you. I know that with a lot of the mental health disorders, there are sleep disturbances.
Yep,
We can
the whole DSM, every one of them, right? Yeah.
Yes, just about. And if we took depression as an example,
Yep.
most people have a sleep disturbance. They're going to sleep too much or not enough. And how can we tease out to what degree sleep deprivation makes depression worse?
So that's the,
Is it the illness itself, depression making a person have a sleep disturbance, or is it
probably
pre-existing
both,
sleep
probably
disturbance?
both, but I will tell you that there's really good evidence of this. If we treat insomnia with cognitive behavioral therapy, so if somebody's depressed and we treat their insomnia, so if somebody's depressed and we give them a sleeping pill, anyway, the point is, if you're getting better from your depression and we treat your insomnia, you stay better. If we don't treat your insomnia, you don't stay better. That wasn't a very scientific way to say it. The same thing is true, though, with substance abuse of multiple sorts, drinking, smoking, right? So if we treat that, but we don't treat your insomnia, so that's not the problem, as you know, these things are comorbid. You don't see the patient until they have the problem, so which came first? But we know if we treat the insomnia, some of that rest of it gets better. We did some work with people that were smokers and heavy drinkers. They were in an earlier study, and that was actually true by treating insomnia. So it doesn't totally answer the question, but yes, it's a mess. Yeah.
Thank you.
He knew the answer, that's why he asked.
It's just more of a comment than a question. question, but I really appreciate you highlighting the interrelationship between like nutrition and physical exercise and sleep. Because I go to see a nutritionist, or I have seen one in the past, and one of the things they're always asking me is, how was your sleep? When I
That's
go,
good.
yeah, when I go to see a nutritionist. So I really appreciate it.
So I've been a volunteer with the American Heart Association for many, many years, and I was already doing work with sleep, and I kept saying sleep support, sleep support. And I'm so excited because they've now come out with all these statements about how important sleep is, and I've been on some papers, and because they always talked about nutrition and exercise.
So have they done studies on gratitude and sleep? The effect of nightly gratitude rituals, and the effect of gratitude and relaxation and sleep?
I don't know, except that if it's contributing to relax, they have done work on mindfulness. I don't know if that's the same concept, but mindfulness, yoga, a lot of those kinds of things are beneficial to sleep. So I would guess it's the same process.
Reciting the
Requires-
ritualistic gratitude list as you fall asleep,
Yeah,
allowing the chatter
yeah.
to be
It's it causes relaxation, right? Yeah. Henry.
Pop-up clickbait. I must see it every day. Never sleep on your right side. Bogus?
I don't know, that's a
Sounds
fire
bogus.
alarm.
You never seen this?
I have not.
Oh, yeah.
digestion, unless you're putting your left.
Unless you.
It says never sleep.
It has to do with your, yeah, probably does, it's probably cardiac, but I don't know.
No truth to it, then.
Yeah, I don't know.
The digestive.
I'll check.
Yeah, digestion, yeah. Stay on your left, it's easier for digestion.
That's true. And with pregnancy, I was gonna mention.
Yeah, that could be the pregnant.
I had a question about the CPAP machine. Is that the same as having oxygen at night? And
No.
what comes out of that CPAP?
What's your question?
It's just air under pressure. Right, it's just air, so it's simply a hose that attaches to a machine that just pressurizes the flow of air. So it's not oxygen, not pure oxygen like you get. Right, no tank. Little machine, little box with a side compartment where you can add water if you want to humidify the air. But that's all it is, just, and you can adjust the pressure. And so when they do the sleep study, they actually will often say, we need an additional study to determine the titration of the CPAP. And how much pressure does this person need to keep that airway open? If it's too little, it's not going to be effective. If it's too much, you could potentially do damage by too much pressure. So that's part of the process as well, is titrating. But just enough pressure to keep the airway open is what we strive to determine.
There are people with serious respiratory problems who might also have oxygen, but that's not the CPAP.
Right.
Like in the hospital, we might do that. Jerry.
Yeah, one comment is we switched to blackout curtains, which made a big difference. But my second thing is, it seems like when I have real trouble sleeping is when there's a full moon. Swear to God, No, it's almost when there's a huge full moon. I'm up.
We're gonna stay away from you, Jerry. Kathy.
No answer?
Is there any correlation if you're taking a medication, say for gabapentin, because you have fibromyalgia?
Yep.
Is there any indication that when you take it has any effect whatsoever on your sleep patterns?
Depends on the drug. I'll let the doctor
Yeah,
answer that.
yeah, timing, yes, it does, it can be impactful. You want to take it with enough interval for it to have a full degree of onset. So it's it's not a defined, you don't have to pinpoint, but there's a general guideline usually to take it.
It's like if you're taking a dose, you would be taking one in the evening, and I was just curious if you would alter that a little bit, if that would somehow at least have some positive effect on sleep.
So the other thing to keep in mind is some drugs really do behave better at different times of the day than others. I won't get into what they are, but we're increasingly realizing that, we talked about your circadian rhythm. So you should, and so we are learning, for example, that certain chemotherapy cancer drugs are better, not just for your sleep, but for your cancer when given certain times of day. And some of that research is just emerging, but it's really important to follow, And all the drugs are different, so, your provider can. Hi.
Is there any way to increase REM?
Why do you want to?
Well, I had a sleep study and they told me that my REM count was very, very low.
Yeah.
And I didn't get much REM at night. And that's really what restorative, isn't it?
Yeah. Yeah, I don't actually know the answer, I should and don't. But the deeper stage of sleep, what we used to call stage 3, 4, now it's called stage M3, is actually restorative as well. So with that, and the other challenge is sometimes when you have less REM and less M3, right? That's also because you're having those little, like the people with sleep apnea, they may have the early stage of sleep, but they're waking up a lot, so they never get into their deep sleep. And that may be part, I don't know what you have to go by what they told you. They didn't give any suggestions?
He said, that was a long time ago.
Yeah, okay.
And I thought, well, all through these years, maybe we made some advances.
I'm not sure I know the answer.
Hi. So not really a question, but just a personal experience that touches upon a lot of what you talked about. My middle son started suffering from sleepwalking. After his first REM cycle, he'd wake up and wander the house. And then that, a few years later, evolved into him waking up at that time and saying he hadn't yet fallen asleep. And he was like upset and anxious and he hadn't been able to fall asleep. And then he wouldn't be able to go back to sleep because he was upset and anxious. And it was months, and we went down, met with a specialist, and a lot of your suggestions were exactly what they told us. The most valuable ones we found through some of my own research and then him exercising all these was making a routine for him at night was really important, really sticking to like a series of like almost like wind down activities, and allowing himself to read for as long as he wanted versus like forcing himself to turn the light off. And then one of the big ones we really found for him, and this was something that we discovered doing our own research, and my brother actually sleepwalking when he had fevers, was a correlation between, especially in pediatrics, them being too warm at night. And they're not necessarily even waking up sweating, but we switched him to all cotton pajamas and got him like cooling bedding, which is kind of a newer thing that's out right now. And they really are cool to the touch, like all the time. And making those changes has made a huge difference. And that's kind of like, when I told him he was coming tonight, he was like, well, I need to go because I don't sleep well.
And I didn't even go near, there are a whole range of pediatric sleep problems, which I did not.
Yeah, I figured I was
sort of. But I did want, there was a slide, I was trying to keep it short, but there was a slide I think I took out, and I wanted to emphasize that 30% of adults claim they don't get enough sleep. When we tested, it's probably more than that. However, 75% of adolescents don't get enough sleep, and it's some smaller percent, but also younger children. So the percentages are high. It's really not well.
And I think heat was an under, like even the specialists we spoke with, they kind of rushed through that side, like they touched upon it, but didn't, and I think that for him was really important, not being too warm at night.
Great, that's good.
A quick aside, you just made me think of something, and that is, a lot of folks aren't aware, parents of young children, that bedwetting, nocturnal enuresis, is a sleep disorder. It's not a disorder of one's urinary tract system. It's a disorder of sleep. They're not responding to the signals of a stretched bladder to wake themselves up to go to the bathroom. So we focus on treating that as opposed to an inherent urinary tract problem.
And it sounds like you did see a pediatric sleep specialist. They are well prepared to deal with those things. So if your child is having a sleep issue, it's good to follow up.
I just have one more question on the opposite of blackout curtains. So we have no curtains in our bedroom. We have very high windows, and I don't need an alarm. I just kind of get up when the sun is up.
Fine.
And is that a bad thing?
If you
Should I
feel
have
good
blackout
during the
curtains?
day, go for it, right? It's some of these suggestions are only if, even what I said about reading in bed, or it's only if you're having a sleep problem, right? If you feel good during the day and you're getting enough hours of sleep, it's fine. And human beings were probably meant to follow that natural And by the way, daylight savings. Sleep disorders community wants to do away with daylight savings. And it's because of that disruption, that change is supposedly affect, and I'm sure it does, but I'm gonna be really upset if I can't sit out on my patio in the summertime. So anyway, I think we kind of used up time. If there's one or two more, I guess we're fine, but thanks for coming. Go ahead.
I just wanted to say that I don't have trouble falling asleep, but 4 a.m. is a big problem. And the brain starts going, and sometimes I can fall asleep at 6. You know, like, that's like the worst thing. And I don't know myself, like, the whole, like, write it down thing, like, you're turning the light on to write it down.
No, don't turn, so what you want to do, again.
You said don't turn it on.
The worst thing is to lay there and toss and turn, like I said. So, and I didn't go into all the sleep suggestions, but what we would suggest is get up, don't lay there and obsess about it. Get up, go sit in a quiet place. You can listen to quiet music or read something very relaxing. Stay there for a little while and then go back to bed. So what you're doing when you're laying there is you're like equating the bed with, you know, difficult thing. The other thing that people say wakes them up is, oh, I have to wake up to urinate. Well, sometimes you do, but sometimes you were awake anyway and you said, oh, may not actually be nocturia. It may be that you were, you know, it was that you were just more awake. But no, just try it. I mean, yeah. You feel rested during the day? I mean,
yeah, that would be a separate occasion.
Yeah. Okay.
Let's have a little consult.